start the cornea part 5, and today we are going to study about the investigations and some of the treatment of the bacterial keratitis. So, we were on the culture and sensitivity report. So, basically, culture and sensitivity is an investigation technique that is used to study about the bacteria that is responsible for the bacterial keratitis. Culture and sensitivity report should be obtained as soon as possible. The type of bacteria will provide an indication of antibiotic category to be used. An indication of resistance on standard sensitivity testing does not necessarily extrapolate to topical antibiotic installation where very high tissue level can be achieved. So basically what is he saying? Basically we culture the organism. We culture in different kinds of media and see if the media particularly grows certain organism, if that media grows the organism, uh, then it is culture positive, and then we apply certain antibiotic and see if the bacteria respond to that antibiotic. That means that they are killed by that antibiotic or not. If there is an resistance, that doesn't mean that it will also apply on the topical antibiotic installation. Tip: corneal scraping should be undertaken in most of the corneal ulceration so that a causative organism can be cultured and its sensitivity determined. So, corneal scraping is a technique how we get the culture and sensitivity. So, now we are going to table 7.3, where we are going to study about the stains of the corneal and conjunctival scraping, and then we are going to the different culture media for the corneal scrapings. So as I told you, basically the corneal staining is to detect certain type of organisms, and also it give us that it is positive or negative, and it indicate that if a bacteria, fungi or microsporidia are present or absent. So staining, what are the staining technique? First of all, very important is a gram staining technique. Gram staining technique is used to uh, determine bacteria, fungi, and microsporidia. But fungi is most importantly KOH staining is used to determine the fungi. Then there is a GIMSA staining. GIMSA staining is used to bacteria, fungi, and acanthamoeba. Acanthamoeba is important for the GIMSA staining. Then there is a calcofluoroid that is also very important for the acanthamoeba, and it can also determine the fungi and microsporidium. So basically, calcofluoroid is basically a stain that is used to stain the acanthamoeba, and after that, the under fluorescent light, it fluorescence. Then there is an acid fast staining that we know with the our pathology lectures, that AF stain is used to determine the mycobacteria species or mycobacteria or nocardia species. Acid fast stain, for example, Z Nielsen or amine O fluorescent. Then there is a Grocott gomorrhoid methanamine silver that is used to determine the fungi, acanthamoeba, and microsporidia. Then the periodic acid skiff is also used for fungi and acanthamoeba. So I want to highlight about the three important stains. That is, here is calcofluoroid, PS, and a GIMSA. So these are all to determine fungi and acanthamoeba. So remember that. Next we are going to the culture media for the corneal scrapings. So there are different kind of culture medias, that is blood agar, chocolate agar, seborrheic dextrose agar, non-nutrient agar seeded with Escherichia coli, and brain heart infusion, cooked meat broth, and Lowenstein Jensen medium. So first of all, we are going to study about the blood agar. So basically the blood agar is 5 to 10% of the sheep or horse blood. So blood agar is a blood, basically 5% sheep or horse blood. So what it is used to identify? It is used to identify the bacteria and fungi except Neisseria, Haemophilus, and Moraxella. We will study where these organisms are um, studied, and basically that is by the chocolate agar. So you can say chocolate agar is blood agar that is more enhanced. So remember that basically Neisseria, Haemophilus, and Moraxella. Blood. So what is a chocolate agar? Chocolate agar is a blood agar in which the cells have been lysed by heating. Does not contain chocolate. So it does not contain chocolate. Basically it is a blood that has been heated. Fastidious bacteria, particularly H. influenza, Neisseria, and Moraxella, are used to study about this diseases. Then is Saborodextrose agar. Saborodextrose agar is basically very important for the fungus culture. It is basically low pH and antibiotic, for example, chloramphenicol, to deter bacterial growth. So why antibiotic is used? Antibiotic is used to kill any kind of bacteria so that we can only see the fungus. So it is used to identify the fungi. Then there is other very important non-nutrient agar seeded with Escherichia coli. So this is basically for the acanth amoeba. Very important, just remember this. E. coli is a food source for acanth amoeba, and it is for the acanth amoeba. So why E. coli is basically a bacteria that we put it into the non-nutrient agar? By because it is a food source for acanth amoeba, and acanth amoeba grow on E. coli. Then there is a brain heart infusion. Rich, lightly buffered medium providing a wide range of substrate. So this is a buffered medium that is providing a wide range of substrate. So it is it is used for difficult to culture organism, particularly suitable for streptococci and meningococci, spores, yeast, and fungal growth as well. Then there is a cooked meat broth. Cooked meat broth is basically developed during the First World War for the growth of the battlefield anaerobes. So battlefield anaerobes were cultured on a cooked meat broth. And what it determines? It determines the anaerobes. Anaerobes, for example, Propionibacterium acnes, as well as fastidious bacteria. We know that P. acnes is very important in which case? In case of chronic endophthalmitis. Then another important Lowenstein-Jensen medium that is used to determine about the Mycobacterium and Nocardia. It contains various nutrients together with bacterial growth inhibitor. Mycobacterium and Nocardia is used. So Lowenstein-Jensen medium is used to have an antibiotics, bacterial and growth inhibitor. So it prevent any kind of bacteria. Then we are going to the treatment. So how we are going to treat about a case of a bacterial keratitis? So in the case of bacterial keratitis, first we have to take the journal considerations. So first of all, hospital admission, discontinuation of the contact lens wear, a clear plastic eye shield, and decision to treat. So hospital admission should be considered for patients who are not likely to be comply or are unable to self-administer treatment. It is also considered for aggressive disease, particularly if only involving one eye. So in what cases we admit the patient? If the patient is non-compliant, if they are unable to administer, for example, old age patient, if they are very aggressive disease, and the only eyed patient. So we have a 4 indications of hospital admission. Then this is very important. We have to discontinuation of the contact lens wear is mandatory. So if the patient is wearing any type of contact lens, a big no for that. Then a clear plastic eye shield. A clear plastic eye shield should be worn between eye drops installation if significant thinning is present. So if there is a very significant thinning, we tend to close the eye between the eye drops. Decision to treat. Intensive treatment may not be required for small infiltrate that are clinically sterile and may be treated by lower frequency topical antibiotic and or steroid and by temporary cessation of contact lens wear. So if there is a very small lesion in the cornea and that is not involving the visual axis and it is sterile, then we use either a top low potency antibiotic and or sometimes with or without steroid, and we sustain the contact lens. Then it is important to note the causative organism cannot it is important to note that the causative organism cannot be identified reliably from the morphological appearance of the ulcer. So it is not important, it is very important that we cannot clinically diagnose only about the disease. We should get the scrapings and culture and sensitivity so we know exactly what organism are causing the bacterial keratitis. Empirical broad spectrum treatment is usually initiated before microscopy results are available, but we do not delay the treatment in this case. We start the broad spectrum antibiotics. Next is we are going to treat with the local therapy. Local therapy means topical therapy. Local therapy. Topical therapy can achieve high tissue concentration and initially consist of a broad spectrum antibiotic that cover most pathogens. Initial installation is at early intervals day and night for 24 to 48 hours, then it is tapered according to the clinical progress. So how we treat it? Basically we start with the broad spectrum antibiotic and then we how it is 1 hour for 24 hours to 48 hour, and then we see the response. If it is responsive, then we taper the dose. So antibiotic monotherapy. So let's see the table 7.4 antibiotic for the treatment of the treatment of keratitis. So we have empirical treatment. Empirical treatment is basically fluoroquinolone monotherapy or cefuroxime plus fortified gentamicin duotherapy. So broad spectrum antibiotics are usually fluoroquinolones, that is moxifloxacin, that is basically used 0.5%, and in case of and we can also use the fortified drops, that is cefuroxime plus gentamicin. Basically the cefuroxime cover the gram positive and gentamicin cover the anaerobes and gram negative one. Its concentration varies with preparation, 5% and 1.5%. Basically cefuroxime is 5% and gentamicin is 1.5%. Then in case of a gram positive cocci, we tend to give cefuroxime, vancomycin or teicoplanin. These are 3 antibiotics that can be used in case of a gram positive cocci. Its concentration of 0.3%, 5% and 1%. Gram negative rods. Gram negative rods are usually covered by fortified gentamicin or fluoroquinolones or ceftazidime. Its concentration are 1.5% and fluoroquinolone and ceftazidime are 5%. Gram negative cocci are usually treated with fluoroquinolone or ceftriaxone. Ceftriaxone preparation is basically 5%. Then mycobacteria, amikacin or clarithromycin is used for mycobacteria. Amikacin is basically 2% and clarithromycin is 1%. And nocardia is also treated with amikacin 2% and 1.6% trimethoprim or sulfamethoxazole. So basically you have to remember that amikacin is used for mycobacterium and nocardia. Next, we are going to study about the antibiotic monotherapy. The antibiotic monotherapy has major advantage over the duotherapy of lower surface toxicity as well as greater convenience. It is best to use one antibiotics because it is less toxic and it has a better concentration, convenient as well. A commercially available fluoroquinolone is the usual choice for empirical monotherapy and appears to be as effective as duotherapy. So fluoroquinolone is basically our first treatment of choice. Because why it is first treatment of choice? Because we don't have to prepare, and there is a risk of contamination as with the fortified eye drops. Ciprofloxacin or ofloxacin are used in a country where widespread resistance to early generation fluoroquinolone has not been identified. So if there is an area where fluoroquinolone there is no resistance to fluoroquinolone, then we use mm, ciprofloxacin and ofloxacin. Activity against some gram-positive organism, particularly some streptococci, may be limited. Resistance to fluoroquinolone have been reported in some areas because it is very commonly used and prescribed medication, so it tends to become resistant now. So where it is resistant, Staphylococcus species, especially in USA, and Pseudomonas in India. So in India, Pseudomonas is causing resistance, is resistant to fluoroquinolone. Moxifloxacin, gatifloxacin, becifloxacin are the newer generation fluoroquinolones that largely address this and also have a better activity against the gram-positive pathogens. Moxifloxacin has a superior ocular penetration. Novel drug preparation with high concentration or modified vehicle have been introduced to enhance antibacterial activity. Ciprofloxacin instillation is associated with white corneal precipitate that may delay epithelium healing. Figure 7.9, we can see that ciprofloxacin has a disadvantage. It has a white corneal precipitates that form, and this prevent corneal epithelial healing. Now then we go to the antibiotic duotherapy. Basically it is a fortified antibiotics which we prepare ourselves with the IV injections. Antibiotic duotherapy may be preferred as a first-line empirical treatment in aggressive disease, or if microscopy suggests streptococci or a specific organism that may be more affected by a tailored regime. So when there is an aggressive disease, when there is a particular microorganism, and for the tailored regime. Empirical duotherapy usually involves a combination of two fortified antibiotics, especially a cephalosporin and a aminoglycoside. So as I told you that two is used, basically cephalosporin is used for gram positive and aminoglycoside is for the gram negative, to cover the common gram positive and the gram negative pathogen. The antibiotic what the problem is, the antibiotics are not commercially available and must be specially prepared. A standard parenteral or lyophilized antibiotic preparation is combined with a compatible vehicle such that the antibiotic does not precipitate. Optimally, constitution should take place in the sterile preparation area of a pharmaceutical dispensary. Disadvantage of the fortified antibiotics include high cost, limited availability, contamination risk, short shelf life, and a need for refrigeration. So basically it is not it has also some disadvantages because it is very high cost and very limited available, and you have to prepare yourself, and there is a risk for contamination, and there is a very short shelf life. You have to make it again and again. So let's see figure 7.9 how 7.5 how we prepare this antibiotic drops. So you can see in this table preparation of the fortified antibiotics. Antibiotics are cephalosporin, which include cefazolin, cefuroxime, and ceftazidime. Basically, its concentration is 5%, 50 mg per ml, which is, and its shelf life is 24 hours at room temperature, at least 4 days if refrigerated. So only if it is at room temperature, it only 24 hours, and if it's refrigerated, then 4 days. How we made it is basically 500 mg parental antibiotic is diluted with 2.5 ml sterile water and added to 7.5 ml of preservative free artificial tears. So what we do is 500 milligram of antibiotic is diluted into 2.5 ml of sterile water, and then in this add to uh, 7.5 ml of preservative free tear. So basically we are giving 500 milligram into 10 ml, that means 50 milligram is in 1 ml, and that makes it 5%. Then there is a gentamicin. Gentamicin has a concentration is 1.5%, that is 15 milligram per ml, up to 14 days if refrigerated. So it can be stored up to 14 days if refrigerated. How we make this antibiotic is 2 ml of the parenteral antibiotic for 40 mg per ml is added to 5 ml commercially available gentamicin ophthalmic solution. So we have a gentamicin ophthalmic solution of 0.3% already available, and we put it in 2 ml of parenteral IV gentamicin antibiotic, which is usually 40 mg per ml. So that is how we make the gentamicin antibiotic. Then comes the subconj antibiotics is usually not indicated if there is a poor, is usually only indicated if there is a poor compliance with topical treatment. If the patient is very poorly compliant, then we tend to give subconj antibiotics. Then there is a Medriatics. Medriatics are cyclopentolate 1%, homoatropine 2%, or atropine 1% is used to prevent the formation of posterior synechiae and reduce pain. So basically Medriatics are used to reduce the pain. Steroid roles is usually controversial, and we give it if the antibacterial keratitis is responsive to antibiotic, and it is usually given 48 hours after the treatment of antibiotic, and if there is a severe inflammation. Steroid reduces host inflammation, improve comfort, and minimize corneal scarring. However, they promote replication of some microorganisms, particularly fungi, herpes simplex, and mycobacteria, and are contraindicated if a fungal or mycobacterial agent is suspected. Beware prior refractive surgery and trauma involving vegetation. So we give it when there is a high inflammation, but it replicates certain organisms, so it is contraindicated that in such cases. By suppressing inflammation, they also retard the eye's response to bacteria, and this can be clinically significant, particularly if an antibiotic is of limited effect or bacteriostatic rather than bactericidal. So if an antibiotic is having a very limited effect, we tend not to give the steroid, because it will just replicate the organism and it will cause the worsening of the disease. Evidence that a steroid improves the final visual outcome is mainly empirical. The steroid for the corneal ulcer trials found no eventual benefit in most cases, but severe cases, counting finger vision or large ulcers involving the central 4 mm of the cornea, tended to do better. So basically there was SCUT trial that was used to study the role of steroid in case of ulcer, and it showed that there is no significant improvement, but in a cases where the patient is counting finger or there is a very large ulcer that is involving the 4 mm of the central cornea, it tend to be better. A positive culture result was an inclusion criteria, and steroid was introduced after 48 hours of the moxifloxacin. Epithelialization may be retarded by steroid, and they should be avoided if there is a significant thinning or delayed epithelial healing. So we not use the steroid if there is a significant thinning and there is a risk for perforation. Corneal melting may occasionally be precipitated or worsened. Many corneal authorities do not commence topical steroid until evidence of the clinical improvement is seen with antibiotic alone, typically after 24 to 48 hours after starting treatment. So we tend to look at 48 hours. If the condition is improved by the antibiotic, then we can start steroid. Otherwise, we do not start the steroid. Other delays they use at least until the sensitivity isolate to antibiotic have been demonstrated, or do not use them at all. So some use it after the if the patient is responsive to antibiotic, and other use if there is a sensitivity report is obtained, and also some do not use it all. Regimes vary from minimal strength preparation at low frequency to dexamethasone 0.1% for every 2 hours, or prednisolone 0.5 to 1% 4 times daily. So what we use a very low steroid, potent steroid, or we use dexamethasone 0.5% for 2 hours, or prednisolone 0.5% QID. Early discontinuation may lead to a rebound recurrence of sterile inflammation. The threshold for topical steroid use may be lower in cases of corneal graft infection, as they may reduce the risk of rejection. So basically, we tend to use a steroid if there is a corneal graft and there is an infection. We use it because it will lead to less chances of rejection. So what are the tip is fluoroquinolone eye drops have a limited effectivity against gram positive organism, particularly streptococci. It tend to do better with the fortified drops. Then there is a systemic antibiotics. When do we start the systemic antibiotics in case of a bacterial keratitis? Systemic antibiotics are usually not usually given, but may be appropriated in following circumstances. Basically, when we tend to use systemic antibiotic when there is a significant thinning, and there is a associated of systemic disease as well, and in neonates as well. Potential for systemic involvement when microbiological infectious disease specialist advice should optimally be sought but should not delay treatment. And meningitis, in which early systemic prophylaxis may be life-saving. Treatment is usually with intramuscular benzyl penicillin, ceftriaxone, or cefotaxime, or oral ciprofloxacin. So when there is a systemic treatment, systemic disease as well, we use it. In case of N meningitis, we use the IM penicillin, or we can use ceftriaxone, or we can use cefotaxime. H influenza infection should be treated with oral amoxicillin with clavulanic acid. Usually augmentin is used for H influenza. N gonorrhea require a third generation cephalosporin such as ceftriaxone. So basically N gonorrhea is treated with the ceftriaxone. Severe corneal thinning. The severe corneal thinning with threatened or actual perforation require ciprofloxacin with its antibacterial activity, a tetracycline, for example, doxycycline 100 mg twice daily for its anticollagenase effect. So there are two antibiotics that can be used with the severe corneal thinning. Tetracycline is very better because it has some anticollagenase effect as well. If there is a scleral involvement, scleral involvement may respond to the oral or intravenous treatment. So there are three things that is indication for the systemic antibiotics. Management of the apparent failure. So if there is apparent failure of a treatment, then what we do? It is important not to confuse ongoing failure of reepithelialization with continued infection. So we have to determine if there is a failure of epithelialization or if there is a infection, continued infection. Drug toxicity, particularly following frequent instillation of fortified aminoglycoside, may give increasing discomfort, redness, and discharge despite the eradication of infection. If no improvement is evident following for 24 to 48 hours of intensive treatment, the antibiotic regime should be reviewed, including contact with microbiological laboratory to obtain the latest report. So if after 48 hours the patient is not improving at all, we review the treatment, and we look at the microbiological report. There is no need to change the initial therapy if this has induced a favorable response, even if the culture show a resistant organism. So if the patient show a resistant organism but the patient is responding to the antibiotic, then there is no need to change the regime. If there is a still no improvement after further 48 hours, suspension of treatment should be continued considered for 24 hours, then a rescraping performed and inoculation on a broader range of media and additional staining techniques requested. Consideration should be given to the possibility of the non-bacterial causative organism. So what we do if even after again 48 or the patient is not responsive, then we stop the treatment. We do 24 hours, we do rescraping and send for more media and sensitivity, and we also look for non-bacterial causative organisms. If a culture remains negative, it may be necessary to perform a corneal biopsy for histology and culture. So, corneal biopsy is the last resort if the patient is not responding at all. Excisional keratoplasty, penetrating or deep laminar, may be considered in case of resistant to medical therapy or for instant or actual perforation. So, this is a therapeutic keratoplasty in which we take the cornea if the patient is not responding to the treatment and there is an impending perforation or a severe thinning. Topical drug and preservative toxicity may cause a failure of corneal reepithelialization, which can be confused with persistent infection. Then there are complications that are associated with bacterial choroiditis, that is perforation, endophthalmitis, and visual rehabilitation. How do we do it? Perforation. A small perforation in which infection is controlled may be manageable with a bandage contact lens. Tissue glue is often adequate for a slightly larger dehiscence. A penetrating keratoplasty or corneal patch graft may be necessary for the larger perforation or in those where infection is extensive or inadequately controlled. Occlusive surface repair technique may be inappropriate in case of some circumstances such as eye with no useful image. So we can say there is a mild, small, medium and large perforation. In a small perforation, we do it with the PCL. We try PCL. In a medium perforation, we use tissue glue, and in very large perforation, we use PKP. Basically, this is what it is saying that. Endophthalmitis, no clear protocol exists for the management of this rare complication, but a similar approach to post-operative endophthalmitis should be considered while continuing specific management of the corneal infection. Secondary sterile intraocular inflammation should not be mistaken for intraocular infection. So we have to treat it just like a post-operative endophthalmitis. So how we visually rehabilitate the patient? Keratoplasty. Laminar may be adequate, may be required for a residual dense scarring. But if corneal scar is set, then we can do keratoplasty. Rigid contact lens may be required for irregular astigmatism, but are generally only introduced at least 3 months after reepithelialization. We use a rigid contact lens if there is a significant astigmatism due to scarring, but that is only used after the 3 months of reepithelialization. Cataract surgery may be required because secondary lens opacities are common following severe inflammation. Even in the absence of the severe corneal opacification, surgery may be hampered by corneal haze, posterior synecdoche, and zonular fragility. So these are the complications that can be associated with the case of a cataract that had a bacterial keratitis. So that's it for the part 5 of the lecture series. We will continue with the part 6 with the fungal keratitis.